The common causes of cough, which is 95 to 5% of cases, are the common causes. Only 5% will fall in the uncommon category. So common causes of cough are usually some sort of upper airway cough syndrome, such as postnasal drip, persistent rhinosinusitis, chronic bronchitis, GERD, cough variant asthma, bronchiectasis, and rarely non-asthmatic eosinophilic bronchitis. And in uncommon causes are ACE inhibitors, bronchogenic carcinoma, interstitial lung disease. Interstitial lung disease is not an uncommon cause anymore, although books will tell you it is a very common cause of persistent cough in a subset of patients. But when you look at a larger variety of patients with cough, it is not that common. But most patients with interstitial lung disease will present with cough as the presenting symptom. And trust me, it is even more than shortness of breath. Cough is the symptom that is most difficult to treat in patients with interstitial lung disease. And rarely psychogenic cough such as cough tics or habitual cough. Okay. Smoking in chronic bronchitis, the common risk factors are smoking or exposure to ongoing irritants such as dusts and fumes. They will typically give a history of expectorating phlegm most days of at least 3 months in a year for the last at least 2 years of time. And if you do spirometry, they usually have a obstructive airways disease with minimal or no reversibility pattern. How do you manage them? First of all, exposure to the noxious fumes, whether it is smoking, whether it is irritants, has to be eliminated or minimized. And you tell them to wear their masks if they are at work and they are being exposed to it. What mask? N95 mask. Number 2 is you give them inhaled bronchodilators if they have irreversible airways disease. Having said that, in our country, it is extremely important to take a proper history of asthma because a lot of patients with asthma who continue to smoke will have a pulmonary function test which looks like a COPD, but they may be chronic asthmatics who are a smoker. So take a good history because this is a variety of patients who will not benefit only from bronchodilators, but will also need inhaled corticosteroids. ACE-induced cough can be present in 5 to 35% of patients who are taking ACE inhibitors, and it can happen within hours or even months after initiation. So if somebody is on an ACE inhibitor and you still can't explain why they are having, consider stopping the ACE inhibitor or switching to an angiotensin 2 receptor antagonist. Please remember that after stopping ACE inhibitors, it may take up to 1 month before you can see any benefit in the cough getting better. So if a patient tells you, doctor, I stopped the medicine, but I'm still coughing, you tell them that you're still getting benefit from the angiotensin 2 receptor antagonist, but it may take you 4 weeks to 3 months to get any benefit out of stopping the medication because it is bradykinin induced. And for bradykinin induced cough, it can take up to 4 weeks for any improvement to be seen. Now, what is upper airways cough syndrome? It occurs basically due to chronic upper respiratory tract irritation and hypersensitivity of cough receptors. Most patients complain of a postnasal drip and frequent clearing of the throat. So what do you see in these patients? They will give a single loud cough. If you all haven't seen, there is a very nice video of Dr. Sandeep Salvi on YouTube showing various different types of cough and what they may represent. And I recommend you go through that video. It's a really good, nice video for you to understand what that a cough might mean when a patient comes into your OPD. Now, on physical examination, very clearly in the oropharynx, if you open their mouth and put the torch, you can see a cobblestone appearance. And that is very suggestive of upper airway cough syndrome. So usually you manage these as you would manage allergic rhinitis, which can be with antihistamines, which can be with intranasal corticosteroids, and with or without a proper ENT evaluation. And it will take nearly about 3 weeks before the patient will actually will tell you that, doctor, I'm feeling better. So whenever the patient comes to you with a cough and you've diagnosed the upper airways cough syndrome, before sending them home with your prescription, tell them that they have to wait for at least 2 to 3 weeks to find any benefit from the treatment that you have given them. Cough variant asthma. This is something I would like us to talk about a lot more than we actually do or realize, because a lot of our patients, especially in today's day and age of pollution, present with this and we don't really realize it. Nearly 28% of patients with present only with cough and have asthma. Inflammatory mediators directly induce the cough or sensitize vagal afferents. And how do you diagnose? So there will always be a history that when I have a cough, it goes on for 3 or 4 weeks and takes long to go away. There is usually a family history of asthma or a history of previous sensitization by a viral infection. And you always do a spirometry. When you do a spirometry, and if you have normal FEV1, don't think that, oh, all is good and sundry, because in most cough variant asthmas, the FEV1 might be normal. Please look for reversibility. Even if the FEV1 is normal, is the post-draw, if you are suspecting cough variant asthma, always do the reversibility testing and look for 200 mLs plus 12% improvement in FEV1. And sometimes you might find significant lability in the small airways, which are indirectly depicted as FEF 2575 in the spirometry that you have. And if you still want to confirm, then a bronchial challenge test can be done, but that's not available everywhere. Simpler way to do it is ask these patients to take a peak flow meter and monitor diurnal peak flow variation at home for 2 weeks. And you will typically find that there is peak flow variation when these patients cough. Give them a 4-week trial of inhaled corticosteroids. And I'm telling you, you will become one of the best doctors in their eyes, because their cough will be improved in most cases of cough variant asthma within 4 weeks of time. And you start it immediately. Non-asthmatic eosinophilic bronchitis, how does that differ? Here, it has in literature, it has been represented as 10 to 30% of chronic cough. Most of these patients will have sputum eosinophilia, but again, how many of us get our sputum eosinophil checked or are able to get it done? They aren't able to get it done. But FeNO levels in these patients are high, but their methacholine challenge test or their spirometry are usually normal. The management again is the same as cough variant asthma. So theoretically, it is actually signified by doing a bronchoscopy and taking bronchial biopsy, which shows significant eosinophils. That is the only way to diagnose it. And pathologically, there are mast cells are significantly increased in the mucosa, but not submucosa, which is how it is different from asthma. This is more theoretical. Why have I brought this up? Because where you find sputum eosinophilia, but spirometry is okay, and bronchial biopsy shows increased levels of eosinophils, that is where it is called non-asthmatic eosinophilic bronchitis. Cough in gastroesophageal reflux disease, in my opinion, this is probably second most important cause, if not the first, in addition to cough variant asthma, which contributes to a significant population of our patients presenting with cough because of our eating habits. At home, everyone tells us you must eat as late as possible. Otherwise, raat ko khali pet kaise rahega? Whereas in the West or in other areas, people will have a supper, which is eat supper at 6 o'clock or 7 o'clock and go to bed around 11 o'clock, giving a good 4-hour time for the food to be digested. But we usually eat very late and within an hour lie down. As a result of that, there can be refluxate, which either by aspiration of the liquid or the acidic gas can irritate hypopharynx and supraglottic larynx, and distal esophageal bronchial reflux increases. And most of these people have silent reflux leading to cough. So 43 to 75% of the GERD patient presents only with cough. So it is not the reflux that makes them present to you, it is the cough that makes you present, and you instead then diagnose them as GERD patients. How do you diagnose it? Obviously, most of them will say there are heartburns or sour taste, but a lot of them who don't have liquid reflux, but just acid gaseous reflux, it is difficult to diagnose. It's a 24-hour pH and impedance monitoring is the gold standard, which your good radiologist, your good gastroenterologist will do for you. How do you manage it? Manages, again, when you're treating for gastroesophageal reflux, PPI and an inhaled corticosteroid are the two cornerstones of treatment. But most important is lifestyle management, which is do not lie down within 1.5 hours of a meal. Avoid high food or beverage which is high in acidity, because they reduce the lower esophageal tone and increase the reflux in these patients. High protein and low fat diet should be prescribed. Head elevated, and do not eat between meals and 2 hours prior to reclining, as I said to you. And you have to explain to them that the cough will respond to treatment average 6 weeks after you have given. But in clinical practice, we have seen usually the improvement starts happening from 3rd week onwards. So sometimes, apart from these 3 important causes or 4 important causes that we discussed, you will need to, in elderly patients who are continuing to cough, who have Parkinson's, who have other neurological problems, rule out recurrent aspiration. So swallow evaluation might be required. A sinus imaging may be required where you're suspecting chronic rhinosinusitis. High resolution CT chest if you're suspecting interstitial lung disease or bronchiectasis. Bronchoscopy where you are suspecting non-asthmatic eosinophilic bronchitis, and bronchiectasis for chronic infections, non-tubercular mycobacterial infections or TB. Their bronchoscopy and a lavage with or without biopsy may be useful. Cardiac evaluation is very important in chronic heart failure patients. They may present with nocturnal cough, especially on lying down. Occupational assessment must be done, and these will help in diagnosing some of the lesser common causes of cough. Unexplained cough can form 0 to 46% of the cases when they present to you in clinic, and 0% is when you have seen so many types of cough that you can always find a cause for the cough, and 46% where your experience is less and you have not excluded other causes of cough. And the reasons for chronic unexplained cough are failure to diagnose, correct diagnosis but inadequate treatment. Very commonly, patients, for example, in GERD, will start a PPI and an inhaler. They might continue with the PPI, but they'll stop the inhaler after 2 weeks because it's not doing them any good. So that is, again, unexplained chronic cough with a correct diagnosis but inadequate treatment. Correct diagnosis and treatment, but they are refractory to treatment, where the ongoing source is going on. For example, you have diagnosed a GERD, they are continuing to take PPI, but they have not made any lifestyle changes. They continue to eat late, lie down late, have high pH, low pH food, etc. So they won't get any better. Only 0 to 10% are unexplained cough if there is evidence-based diagnostic protocol followed. So in cough, diagnostic protocol is very important. As I said to you, start excluding from the upper airway to the lower airway, to the GI cause, to the neurological cause, to the medicine or the pharmacological cause. And chronically heightened cough reflex sensitivity is the most common reason where you fail to have a reason for your cough. So common pitfalls in diagnosis, as we just said, is failure to recognize that the etiologies of chronic cough may be multifactorial. And more often than not, there will be patients who will have a GERD, who will also have a upper airway cough syndrome, and along with that may have an asthmatic tendency. Most commonly, patients who present with obstructive sleep apnea, the significant proportion of them have asthma. So if you give a patient with obstructive sleep apnea a CPAP machine, but fail to diagnose their asthma, not only will they not use the CPAP machine that you have given them, but they will also tell you that their cough gets worse when they use the machine. And that is because their bronchodilation is not there. On top of that, when the machine is there, the bronchoconstriction worsens and the cough worsens. So you must, before giving any OSA patient a CPAP machine, do a pulmonary function test for them to exclude associated asthma. In management, in pitfalls in management, this slide is very important. Premature abortion of treatment, which is stopping treatment, especially in asthma and upper airway syndrome. You must continue treatment for at least 4 weeks before saying that the inhalers are not getting better. In GERD, they start getting better from 6 weeks onwards. And in proven GERD, you may need to treat them even up to 6 months to get maximal benefit. Usually it is 6 weeks to 3 months that the treatment that we give. In a small proportion may have to give to up to 6 months. Failure to recognize environmental exposures and comorbidities, especially in asthma, upper airway, in cough syndrome, etc. Unless you avoid the allergens that are causing the problems, only giving them inhalers is not going to help. Therefore, identify allergens. In most cases, it is dust mites. So avoiding using hypoallergenic pillows, using mattress protectors, wearing masks outdoors, and avoiding dust-related areas may help them. In GERD, as we said, treat the OSA, the food that they're eating, and the lifestyle that they're leading. And do not prematurely, please, label people with psychogenic cough, idiopathic cough, or unexplained cough.